Hi all, welcome back to Emergency Medicine lecture series. The current lecture we are going to discuss about approach to patient with chest pain. Chest pain is one of the most common presenting symptoms to the ED. It can be cardiac or non-cardiac. Again, it can be emergent to a routine chest pain. I'm Dr S Prakash Babu, Associate Professor, St. Peter's Medical College, Hosur. Chest pain constitutes about 9% of all ED visits. Incidence is on the decline in the Western countries, whereas the incidence of non-communicable diseases along with CAD is on the rise in developing countries like India. Daga et al. Stated that prevalence of chest pain in India is 15% of all ED visits, compared to 9% of all ED visits in Western population. It's about 15%, 6% more in the Indian guidelines. CAD is the leading cause of chest pain in a study done in 2014 from India. Discovered with several life-threatening and benign conditions. Coming to the pathophysiology of chest pain can originate from the somatic nervous system or the visceral nerves. Somatic pain is from the skin, chest wall, and the parietal pleura. Visceral pain is from the pericardium, heart, lungs, and the lung parenchyma. Usually, somatic pain is carried by somatic afferent fibers to the spinal cord and are mapped to the corresponding areas of the cortex in the brain. Visceral pain is usually carried by visceral fibers from lungs, heart, trachea, esophagus, and the great vessels. It is related to the dorsal ganglia and mapped to the cortex. If you compare visceral and somatic pain, visceral pain is imprecisely located. Patient cannot point visceral pain with a single finger point of maximum pain, and it's difficult to describe. Most of the time, patients use terms discomfort, heaviness, pressure, tightness, or aching. They won't describe it as a specific type of pain. Most commonly, visceral pain is referred to an area of the body corresponding to adjacent somatic nerves. So it can be felt in an area away from the actual organ of impact. Is called referred pain. Whereas somatic pain is usually described as sharp sensation, severe ache. Patient is able to precisely locate with a single finger. There is no referral and radiation as it is already arising from the somatic area. Coming to the pathophysiology of chest pain. Chest pain, as I told, can originate either from somatic part of the body or from the visceral organs. Visceral organs, most common cause of chest pain is coronary artery disease. First of all, there is atherosclerotic narrowing of the blood vessels, which reduce the blood flow. Anaerobic metabolism sets in, and there is lack of oxygen to the tissues, and the improper clearance of waste like lactate, which causes ischemic chest discomfort. On the other way, the serious side of the same disease, there is an atherosclerotic plaque which has a rupture. Blood flow ceases to the area because of clot formation and complete blockade of the vessel. This is tissue death. This tissue death leads to accumulation of waste and this ischemic chest discomfort. That leads to apoptosis and inflammation along with pump failure that can lead to inflammatory pain at a later date. On the somatic side, there is injury and inflammation of the skin or the skeletal structures with activation of free nerve endings supplying those areas. Somatic inflammatory pain will occur. There is inflammation of the pleura. There is activation of free nerve endings supplying the pleura. There is pleuritic chest pain, usually you can heard as a pleuritic rub. Whenever this pain occurs, there are psychological factors which influence the reaction to pain, and there is activation of sympathetic nervous system when there is visceral pain. The sympathetic nervous system will modify the amount of pain perceived and the further reactions associated features with the pain like sweating, dizziness, Those are the complaints along with your chest pain. Come to the differential diagnosis of chest pain. It is very wide. It can be divided into critical diagnosis, emergent diagnosis, and non-emergent diagnosis, and based on the systems. When it comes to system, cardiovascular system, pulmonary system, and sometimes gastroesophageal system are the most commonly involved in critical and emergent diagnosis, which can be life-threatening. In the cardiovascular system, the emergent diagnosis include acute myocardial infarction, where there is complete blockade of the flow and there is death of the tissue. Acute coronary ischemia like NSTEMI, where there is only subendocardial ischemia. Aortic dissection, which is a catastrophic condition, and cardiac tamponade can also cause chest pain. Emergent diagnosis, which need to be treated as early as possible, but they're not immediately life-threatening, like unstable angina, coronary spasm, rheumatic angina, cocaine-induced pericarditis or myocarditis can lead to chest pain. The non-emergent cardiovascular causes, usually the valvular heart disease, aortic stenosis, mitral valve prolapse, and hypertrophic cardiomyopathy. The pulmonary system critical diagnosis are pulmonary embolism and tension pneumothorax, especially when pulmonary embolism is massive. Emergent diagnosis, usually simple pneumothorax and mediastinitis. Non-emergent diagnosis include pneumonia, pleuritis, pneumopericardium, and tumors. The gastroesophageal system, there is only one critical diagnosis, which is Borjas syndrome. Borjas syndrome is nothing but rupture of esophagus when there is a repeated retching and forceful vomiting. The emergent diagnosis is Mallory-Weiss tear. Mallory-Weiss tear is the rupture of only the intimal layer of endothelial layer of the esophagus. And then the non-emergent diagnosis, esophageal spasm, peptic ulcer, biliary colic, GERD can also lead to chest pain. The musculoskeletal system, muscle strain, rib fractures, arthritis, tumors, costochondritis, non-specific chest wall pain, all can mimic your myocardial infarction. Neuropsychogenic causes include spinal root compression, thoracic outlet syndrome, herpes zoster, and post-herpetic neuralgia. These are the differential diagnoses for chest pain you should consider whenever you are evaluating. Once you have a patient with chest pain in the ED, the first step you need to do is, as always, a rapid stabilization and simultaneous assessment of the patient. Check vitals and triage immediately. Irrespective of the patient's vitals, all patients with chest pain should be triaged to greatest triage category, that is the red category first. Once you evaluate the patient, you can always downgrade whenever required. Perform and interpret an ECG within 10 minutes. This is the norm prescribed by AHA. Within 10 minutes, you need to do an ECG and interpret the ECG to look for any changes that tell you about myocardial injury. Clinical questions to be asked to yourself include: should I intervene now? Depending on your ECG findings and the patient's vitals. Are there any life-threatening possibilities in this patient? If you can answer these two questions, you have a diagnosis and you're going to save the patient. Needle compression in case of suspected pneumothorax is essential during the primary survey. Take focused history and perform focused physical examination. Don't waste time unnecessarily in obtaining an elaborate history and performing an elaborate examination in the initial stage. Once the patient is stabilized, you can always take elaborate history and you can examine the patient thoroughly at a later time. The main historical points that you should ask are: ask the patient to describe the pain, use Socrates to evaluate the pain. Duration of pain is an important determinant of management. If pain is less than 12 hours or greater than 12 hours is more important question. Pain is less than 12 hours and there is an acute MI, you can always thrombolyze the patient. If it is more than 12 hours, you should always go to a primary PCI. Diaphoresis, anxiety, apprehension indicate visceral pain. All these are because of sympathetic system overactivity. History of previous similar episodes will give you crucial information over the patient. Never ever miss a chance to go through the old records that the patient might bring. Evaluate for risk factors for a particular disease, like your risk factors for cardiovascular disease, risk factors for aortic disease, risk factors for pulmonary disease, and collect a sample history as always. This picture here shows the non-modifiable risk factors and the modifiable risk factors for coronary artery disease. The non-modifiable risk factors are age. As a general dictum, as the age increases, the risk of myocardial disease, not only myocardial disease, any vascular event, the risk of any vascular event will increase with age proportionately. Gender, because of estrogen production in females, males are at higher risk for vascular events. Genetic factors, race and ethnicity are also non-modifiable risk factors. Modifiable risk factors include high BP, hypertension, which can be appropriately treated to prevent any vascular events. Cessation of smoking is very, very important. Smoking is a risk factor. Diabetes mellitus, physical inactivity, obesity, and high blood cholesterol, which all can be treated and managed successfully with lifestyle modification and also with medications. Coming to the physical examination findings, look for appearance, whether the patient is in acute respiratory distress or diaphoretic. Usually, when patient is in acute respiratory distress or diaphoretic, the diagnosis include PE, tension pneumothorax, acute MI, pneumothorax, aortic dissection, unstable angina, cholecystitis, and perforated. Check the vital signs. Hypotension is a feature of tension pneumothorax, nasopulmonary embolism, acute MI, aortic dissection, coronary ischemia, esophageal rupture, pericarditis, and myocarditis. Tachycardia is a symptom of due to sympathetic overactivity. It is a symptom of a serious disease. Bradycardia is a terminal or pre-terminal event before the patient going into cardiac arrest. Hypertension in acute MI, coronary ischemia, and also left ventricular failure, aortic dissection. Fever in PE, esophageal rupture, pericarditis, myocarditis, mediastinitis, all inflammatory conditions. Hypoxemia is a feature of pulmonary embolism, tension pneumothorax, and pneumothorax. The cardiovascular examination, significant difference between upper extremity blood pressures, that is called radial delay, present in aortic dissection, narrow pulse pressure present in pericarditis with effusion, a new onset murmur usually present in complications of myocardial infarction, mechanical complications of myocardial infarction like three-valve rupture, or valvular rupture, cardiotendinous rupture, acute MI, aortic dissection, and coronary ischemia. S3 and S4 gallop in acute MI, coronary ischemia. Pericardial rub in pericarditis, audible systolic crunch and cardiac auscultation, esophageal rupture, mediastinitis. Is audible systolic crunch or cardiac auscultation is called Hammond's sign. Jugular venous distension is present in acute MI, coronary ischemia, tension pneumothorax, PE, and pericarditis. Coming to the pulmonary examination, unilateral diminished or absent breath sounds, then tension pneumothorax or pneumothorax. A pleural rub can be present in PE or pleuritis, subcutaneous emphysema, and tension pneumothorax, esophageal rupture, pneumothorax, and mediastinitis, wherever gas can leak into the subcutaneous tissues. Rales are present in acute left ventricular failure due to MI, coronary ischemia, and unstable angina. Abdominal examination, epigastric tenderness is found in esophageal rupture, esophageal tear, cholecystitis, and pancreatitis. Left upper quadrant tenderness is present in pancreatitis, right upper quadrant tenderness and cholecystitis. Extremity examination, unilateral leg swelling, warmth, pain, tenderness, or edema, which indicate a DVT, can be present in pulmonary embolism. The neurologic examination, focal findings can be present in acute dissection, stroke in acute MI, and coronary ischemia. In aortic dissection and coronary spasm can occur. Ancillary testing, the one most important bedside investigation that you can do whenever you are stabilizing a patient with chest pain is the ECG. Look for any new injury, any new ischemia, RV straight pattern, or diffuse ST segment elevation, which indicates pericarditis. The chest X-ray is useful, especially in pneumothorax with mediastinal shift, tension pneumothorax, wide mediastinum, pneumothorax effusion, increased cardiac sulfate, and pneumomediastinum. EBG is almost always useful to look for hypoxemia and AA gradient to definitely pinpoint where is the problem with oxygenation. A spiral side CT or VQ scan can positively diagnose pulmonary embolism. Coming to the evaluation and management of cardiac chest pain, you need to follow the AHA guidelines, AHA cardiac MI algorithm, complete initial evaluation, initiate emergency care, attached to multi-channel cardiac monitors, oxygen therapy, aspirin, nitroglycerin, IV access, and laboratory tests. If you are suspecting ACS based on your ECG, look for acute STEMI, ST elevation greater than 1 mm or new onset LBBB. If they are present, most definitive management is PCA. But you can consider heparin or low molecular weight heparin, IV nitroglycerin, beta blockers, revascularization, fibrinolysis, or GP2B3A inhibitors, plus PCA. You suspected ACS, but the ECG is normal, stable angina is resolved, patient can be discharged home under specific care. Evaluation and management of non-cardiac chest pain. Complete initial evaluation has to be done. Attach the patient to the cardiac monitor, intravenous access should be obtained, oxygen therapy should be initiated. Differential diagnosis should be based on the history, physical examination, ECG, and specific tests can be performed. Once you have done specific tests and you have diagnosed the condition, if you are suspecting aortic dissection, beta blockade, and IV antihypertensive therapy decreases contractility, immediate surgical consult and transfer is needed. You are suspecting pulmonary embolism, IV heparin, or subcutaneous low molecular weight heparin can be given. Thrombolysis if severe cardiovascular instability should be considered. Tension pneumothorax, first and foremost, diagnosis evaluation you need to use a needle decompression followed by placement of a tube therapist. Esophageal rupture, resisted with IV fluids, provide analgesia, IV antibiotics, and any surgical consultation should be taken. For pericarditis, ultrasound for effusion, tamponade risk is present, NSAIDs can be given to reduce the pain, corticosteroids can be given to reduce the inflammation, and obtain cardiology consultation as early as possible. Thank you. Please don't forget to share and subscribe the videos. Thank you once again.